Hello again. In this section, I will share with you the animation clips in order to describe the extra-levator abdominoperineal excision technique. I would like to take this opportunity and thank the animation team for their incredible work. Before proceeding, however, with the dissection, let's view the surgical planes from both the abdominal part and the perineal part as shown in this animation in sagittal view. Also note that blue dotted lines represent the abdominal dissection plane and the red dotted line represent the perineal part of the dissection. Same principles and dissection planes are followed with mesorectal excision concept in the abdominal part of the operation, as well as, however, dissection must be completed at the level of sacrococcygeal joint in the posterior plane, just below the autonomic plexus on both lateral sides, and finally at the level of either vesiculus seminalis or vagina at the anterior plane. The aim of this procedure is to leave the levators on the mesorectal fascia and to have a wide surgical margin during extra-levator abdominoperineal excision. At this point, the abdominal dissection is completed, and then the patient is turned over. Following the completion of the pelvic dissection, perineal dissection planes are shown in detail in this animation. Elliptic skin incision allows us to reach the surgical dissection plane, and the anal sphincter complex is encountered. Dissection is continued just outside the external anal sphincter and then carried out between the ischianal fat tissue and the levator muscles. There is no need to remove the ischianal fat tissue unless the preoperative radiologic imaging shows invasion to these tissues. The dissection is continued laterally within this perimuscular plane until the levator muscles reach the lateral border of the pelvic floor. Here, transection of the sacrococcygeal ligament and the start of the dissection at the extra-levator plane is viewed. The removal of the coccyx with the specimen gives us wide surgical margin, providing us with space for the removal of the rectum. In order to achieve wide surgical margin, the pelvic floor muscles must be removed and blocked with the mesorectum. Levator muscles is transected at the border of the lateral pelvic side wall. This transection is carried out from posterior to anterior at both lateral borders of the pelvic floor. As a result, mesorectal fascia is observed from the perineal wound. Then, the specimen is removed from the perineal wound. This maneuver allows us to view the anterior dissection plane of the rectum clearly. Progress has to be made under direct vision and sharp dissection between the rectum and the urogenital organs, the ductus deferens, seminal vesicles, and the prostate. Now, let's observe the perineal dissection planes in sagittal view. Patient is turned back and the posterior dissection under direct vision is started. Surgical incision from coccyx, the perineal body is performed around the anus. The posterior dissection is carried out between the ischianal fat tissue and pelvic floor muscles. Extra-levator dissection plane makes its way outside the external sphincter and levator muscles. This dissection continues to the top of the sacrococcygeal ligament at the posterior, to the lateral border of the pelvic floor at both lateral sides, and finally to the perineal body at the anterior part. Then, sacrococcygeal joint is transected. This allows us to enter the mesorectal dissection plane, which had already been carried out from the abdominal part. Following the transection of the levator muscles at both lateral borders of the pelvic floor, specimen is removed from the perineal wound, resulting in performing sharp dissection under direct vision within the correct dissection plane. The anterior dissection plane continues between the vesicula seminalis, the prostate, and the rectum. Then, eventually, the specimen is extracted. The large perineal defect can be closed by a mesh graft.